Good morning. Let me see if I can. I'm Rick Stubner. I'm one of the cardiologists at Baylor Scott and White Health. I work at our Buda and our Oak Hill locations. I'm going to talk to you about heart health and then cover some healthy lifestyles. And if you have any questions as we go, you can just sort of raise your hand on the Zoom feature, and we'll try to catch it as we go. I think we have a crowd where we can just answer questions as they come up, or if you just want to save them to that's okay too. So anytime I talk about heart health, I like to start graphic from the American Heart Association. It's called My Simple Seven. Let me go back up there just a second. This is just a nice framework that we like to use. I use it in the office. Probably if you have a primary care doctor, they use something like this too, just to get a basic framework on what our risks for heart disease are, and what things should we be looking at and what should we be doing to sort of maintain a healthy lifestyle. If you kind of think of this as a clock face going from 12 o'clock, the 7 categories are nutrition, optimal weight, exercise or movement, smoking cessation, blood pressure, cholesterol, and blood sugar. Something I really like about it too is if you look at the first half, sort of from 12 to 6 o'clock, most of those are things that don't even require you going into a doctor's office that you can do on your own. And I guess increasingly some of the things on the second half of the clock phase could also be done as well. So when you see a doctor, when you see a cardiologist, a primary care physician, somebody in the wellness sphere, they're going to sort of look at this framework as sort of how to initiate a discussion. So I like to use it as well when we talk about heart health in this format. So, it seems sort of simple, but I think it's very important to emphasize how important these basic concepts are. And this is a relatively recent study that sort of demonstrates that. It was from Sweden. Title is Low Risk Diet and Lifestyle Habits in the Primary Prevention of Myocardial Infarction in Men, which means heart attack. So this is, it's a relatively simple study. There was no intervention or treatment. It was just they looked at a slice of the population and followed them over time. So this was Swedish men aged between 45 and 70 years old, and followed them for 11 years and ended up with a total of about 20,000 patients. Essentially what they did is wanted to identify and advance low risk behaviors and see what the outcomes were in respect to heart attacks over time. So their low risk behaviors were: 1, a healthy diet, which they defined as 5 daily servings of vegetables and fruits, 4 servings of whole grains, and a little over 2 servings of fish each week. The second one was no more than low risk alcohol intake, so moderate consumption of 10 to 30 grams per day, roughly a serving or 2, so no more than that. The next one was no smoking, or they quit more than 20 years ago. Physical activity was defined as 40 minutes per day of walking or biking. This isn't for exercise, it's for transportation or moving around. And greater than 1 hour per week of exercise, and then a waist circumference of less than 37.5 inches. So those are the 5 factors, no comment on medications or anything else, and said, okay, if these factors were present, how did these people do over time? So the idea behind this is that if you have these low risk lifestyle practices, if you look on the left, in theory, each of these sort of contributes to improved physiology. So lower blood lipids, which is cholesterol, lower blood pressure, reduced oxidative stress, endothelial function is improved, better glucose tolerance and insulin sensitivity, less blood coagulation, which is clotting, less inflammation, and maybe improved cardiac function. And interestingly, some of these factors that we're seeing in that sort of center circle are some of the issues that seem to increase the risk of COVID. So conditions that sort of raise your oxidative stress, raise your blood pressure, inflammation and coagulation also sort of are associated with increased risk in COVID. So some of these things we've heard about healthy lifestyles being helpful for sort of dealing with during the pandemic may have some crossover effects. What they saw in the study is that as you add each of these healthy behaviors, so if you look from health, if you add a healthy diet, you get a reduction of heart attack in those patients by 16%. And as you sequentially add each of these low risk lifestyle practices, you start seeing additive effects to the point where if all 5 of these factors were present in somebody, there was an almost 80% reduction in heart attacks when they looked at these compared to the normal population. And again, there's no intervention, there's no medications looked at, it's just looking at lifestyle behaviors. So I think it really highlights how important and how foundational getting those basic things of diet and exercise and weight management and all these things, getting those established as the foundation of heart health and healthy living. So I'll cover them each in a little bit more detail, and starting with the first one on the clock face, which was nutrition. Now, this is one of those complicated ones, trying to, well, what do I eat? Because there's so much conflicting news. You get sort of the back and forth. There's always sort of a new fad diet or a new story that says I can eat this, and the next day said, no, you're not supposed to eat that. I don't think that there's probably not one diet worldwide, and people have adapted to so many different climates and geographies and so forth that and have found food adaptations for those areas. Although we do say the one diet we're probably not adapted to eat is the standard American diet. It's too calorie dense, too much refined processed carbohydrates, too much sugar, salt, and fat. So as a general rule, if we put a name to a diet, I usually like to say a Mediterranean type diet. And what that means is you want to enjoy vegetables, fruits, whole grains, beans, legumes, nuts, plant-based proteins, lean animal proteins, poultry and fish. You want to try to minimize or limit, sweetened drinks, processed foods, processed meats, deli meats, hot dogs, sausages, things like that. Any kind of refined carbohydrates with added sugars, whole fat dairy, any kind of whole fat animal products, and then highly processed foods. And then trans fats and these oils like coconut and palm, these partially hydrogenated oils, are just not healthy. And that's kind of at the bottom. You really just don't want to eat any of the trans fats or partially hydrogenated oils. So, we're omnivores, and so we can sort of eat lots of different things. And so I think that a reasonable goal is to always let's try to aim for the 80 to 90% solution. And if you can kind of get that right, there's always going to be the meal out or the food on the run or the family dinner or something that may not have the healthiest options. But if you're getting it right most days of the week, those individual meals aren't going to necessarily be a problem. Another diet, this has kind of been a proposed diet. We call it a Pesco-Mediterranean diet pyramid that I think is a pretty good way to think about it. Basically, you want the bulk of your carbohydrates to be vegetables and fruits. Your fats, you'd like to be unsaturated, plant-based fats, omega-3s from fish, things of that nature. Your proteins, you want to be healthier proteins from a leaner animal protein, or at least a healthy animal protein. And then watching your intake of saturated animal fat and red meat. If you do eat red meat, I grew up in Texas too, you want to make sure it's good quality. If the animal was fed junk or not what it was meant to eat, you're not getting something healthy either. And so in terms of hydration, water is the best beverage. They're kind of at the bottom. It's, coffee or tea are probably okay. It's just what you add into them. Sugar sweetened beverages and fruit juices just have too much added sugar to be considered healthy. And the last thing they discussed down here, which I think is kind of interesting, is this idea of sort of eating within sort of a time window. I think in one way to simply think of it is try to avoid snacking after, right before going to bed or early in the morning. If when you're getting ready to go to sleep at night, your body isn't getting prepared to process a bunch of food. So if you're eating late at night, you're essentially just going to store all that as sort of fat, because your body's not really in a situation where it wants to process. This slide is not an official dietary guideline, but I think if you're looking for a general framework of how to approach a healthy diet, I think this is a reasonable place to start or to work off of. Another simple way to think of it is, if you think everything in the middle of a grocery store, it doesn't look like what would have been food 1,000 years ago. It's probably, maybe it's a little bit too processed, and try to look for something different. So in terms of calories, generally speaking, if you kind of think of calories in and calories out, it's still helpful. It's not the entire answer, but I think it's helpful. I was looking recently at some carrots in my refrigerator, and a serving of carrots, which is I think a third of a cup, something like 40 grams, and it was 30 calories. And then I pulled out a Hershey bar, which was half the number of grams, but it had 200 calories. So if you just think of the mass of it, if I eat that serving of carrots, I'm going to probably feel full longer and not get quite such a spike in my blood sugar. And then just the mass effect of taking up more room than the candy bar, I'm going to do so for probably about a sixth of the calories. And so if just knowing what the calorie content is of foods that you eat is sometimes quite helpful in knowing what you're eating and how much you should be eating. So in terms of, well, how do you sort of go about this, and tips and tricks for weight loss? I think a good way to think about it is, well, how do you accomplish goals? How do you get things done? How do you motivate yourself to do things, and sort of apply that in the same way? I personally do better when I chip away at things. So if let's say like 15 years ago, I probably used to drink soft drinks, Coca-Cola stuff quite a bit. And I was like, okay, I need to get away from this. How am I going to do it? Instead of just going cold turkey, I'm like, well, first let's switch to maybe like Coke Zero or something like that and see if I can cut it. Then if that seems kind of easy, let's try to cut it back. If I'm doing 2 days, let's go to 1 a day. And then if 1 a day is easy, let's go just 3 times a week. And then I just kind of do a little bit at a time until whatever the change is has become a habit and it's easy. And then I can kind of keep adding to that. I have some patients that say, look, that doesn't work for me. If I have one potato chip, I'll have the whole bag. I just have to go cold turkey. If that's that's what works for you, then that's okay. I feel like if you try to do too many things at once, a lot of people do every New Year's, you kind of just go all in on everything. It becomes so difficult and it's almost traumatic that you tend to, it's easy after 4 to 6 weeks to sort of give up on it. And really where the benefit comes in that momentum and the sustained change in your dietary pattern, the sustained change in your physical activity level. And so the discipline is in then doing it every day or keeping up with it as much as possible. Also, though, don't be easy on yourself to the extent that if there is a day or a week where it doesn't work out like you had, the schedule is hectic or there's an ice storm or whatever, you just, okay, well, I'll do better next week. And then just kind of stay on that path. Think of it as a journey or a path you're on, as opposed to just if you fail any one time, you just need to give up. In terms of physical activity, the goal is to get 150 minutes of moderate aerobic activity a week or 75 minutes of vigorous activity. And so if you think of moderate aerobic activity as just that level to get where you feel like your work of breathing is up, you're breathing hard, but you're still able to carry on a conversation, that's sort of a goal. Most people get there, just a brisk walk up an incline is enough to get you there. So, and this is all additive. So you doesn't, mentioned earlier, you can walk around the building today because it's cold. That all counts. I think the general takeaway is we need to move more. We don't do well when we sit, and so we need to keep our bodies moving. But we need to keep our bodies moving sensibly. We don't need to sort of be out running marathons and triathlons to get the benefits. If you think about 150 minutes of exercise, that's about 20 minutes a day. And so, or if you want to break it up, you could do 30 minutes every other day or something like that. The vigorous aerobic activity would be sort of a more intense level where you're not able to carry on a conversation. I like this talk by Dr. O'Keefe. You could find this on YouTube, on TED. Dr. O'Keefe is a preventive cardiologist up in Kansas. He used to run triathlons until he sort of realizing it probably wasn't the optimal thing for his health as he got older. And is saying it's not survival of the fittest, but it's survival of the moderately fit. And I tell this to people every day. You don't need to go out and overdo it. We just need you to move. And again, build on a trend of just getting out and going for a walk. If your knees or back don't allow for that, a stationary bike or any kind of low impact or no impact type cardio workout is a good place to start. And even if it's 5 minutes at first, just take it. 5 minutes is great. I know the feeling of not wanting to do stuff when you're getting home from work, but sometimes if you can just sort of coax yourself, you just put on the shoes and get out the door. Sometimes it's a little bit easier to get moving from there. So, and again, I think the discipline is in the habit more than any one particular workout. If you go work out for 1 or 2 hours the first time, but then you're so sore you can't move for a week, it sort of defeats the purpose. Just get started easy and then build in the recovery and then just kind of progress from there. Blood pressure, high blood pressure probably is the number one world risk factor worldwide for cardiovascular disease. And that, so when we talk about cardiovascular disease, we don't just mean heart disease, we also mean strokes and heart failure and all the other conditions that come with it. And so knowing your blood pressure, monitoring your blood pressure, and managing your blood pressure is of critical importance. When we're talking about blood pressure numbers, there's the sort of the top number and the bottom number. The top number is called the systolic number, and it's going to be the higher number. That's the pressure in your system when your heart is contracting and pushing blood out to the body. The lower number is the diastolic number. And so that's the number, quote, when the heart is relaxing or opening back up to allow blood to return to the heart from the body. Interestingly, the heart actually gets its own blood supply during that diastolic or relaxation phase. That's when that perfusion occurs. Essentially, the optimal blood pressure is less than 120/80. Probably about, if you were to be buying life insurance, you'd probably about a 110/70 is probably about the very best blood pressure. Even lower than that is probably certainly not harmful. Once you get probably below like 100/60, it doesn't need to be lower than that. And in some cases, if people are on medications and maybe they're lightheaded or something, that's a sign that you're on too much medication. In rare cases, we actually try to get people to those low blood pressures if they have heart failure or other conditions, because it does reduce the workload of the heart. But in general, for everyone else, 120/80 or less is considered optimal. Now, when does it considered to be considered high blood pressure? They've changed the criteria in the last few years. So now anything over 130/80 is actually considered high blood pressure. Now, when you actually get treated for high blood pressure, meaning taking a prescription medication, that varies with your health and your risk factors. But they've moved those numbers down quite a bit in the last few years. The traditional number used to be 140/90 that I was taught when I was in medical school. I think the reason they made that change is even within the spectrum of normal blood pressures, each time the blood pressure goes up 20 points systolic or 10 points diastolic, there's a doubling of the risk of cardiovascular disease. So I think that just highlights the importance of getting the blood pressure as well controlled as possible. Now, if you're normal and you're doubling, you may be doubling from a very, very low number, but we want to be very aggressive with treating the blood pressure. Now, in some cases, we do have to worry about over treating people. So, we're trying to, the blood pressures are constantly fluctuating and changing. So oftentimes we'll ask people to record their blood pressures periodically and maintain a blood pressure log and see what are the highs, what are the lows, what are the averages of the resting blood pressures over a period of time, so we get a sense of where those numbers are. When the numbers get very high, over 180 for the top number and 120 for the bottom diastolic number, then that's concerning, and we like to get that down within days to weeks. So, hypertension often gets called essential hypertension, and hypertension being high blood pressure, meaning we don't know why it happens. It's just one of those things that the traditional thinking that we have is just something that most adults develop as you get older, and there's a slow rise of your systolic blood pressure that just comes as a natural consequence of aging. That may not be true. As if we're talking about healthy lifestyles, this is a study it's quite old now, from the British Medical Journal from 1990, but sort of questioned this idea that high blood pressure was just something that we get as we get older. This is called the Kenyan-Luo migration study, and it was observations on the initiation of a rise in blood pressure. And so what this study group did was look at Kenya and look at people who were living in their essentially their hometowns or their villages, that then moved to the capital city of Nairobi, and compared them to people who stayed in the village. Now when the moving from the village to the capital city usually resulted in a change in the diet or activity level. So that they would see more circulation, less movement, walking. And what they wanted to do, see, was there sort of an association or change in blood pressure that came as a result of this. Okay, I think I'm back. Sorry, I think we had an internet drop, so let me just jump back into it. Let's see. Okay, can everybody hear me again? Okay, got it.
Yes.
Good. Sorry about that. I don't know what happened. Okay. It looks like, so I think we lost you right on this slide, but I think this idea that, or this study to me was really interesting because it kind of calls into question this idea that we're just going to get high blood pressure. And so I think it also highlights the importance of, these lifestyle factors can potentially prevent the onset of high blood pressure. And the other thing I point out to people, look, maybe the blood pressure is too high. We really do want to start a blood pressure medication, but the dose of the medication maybe could be minimized, or maybe the need to add additional medications could be prevented if we are able to still focus on the exercise and the healthy diet and the healthy weight. Smoking, I think everyone knows. If you don't, you shouldn't smoke, and if you do smoke, you should quit. This is the most preventable cause of death in the US, not just from heart disease, but lung cancers as well. You could really extend this to any sort of air pollution. Diesel combustion products, for example, are highly atherogenic in our blood vessels and aren't healthy. So just like you want clean water, you probably want to breathe in clean air. The good news is if you quit smoking, your risk of heart disease does go down. So within a year, we think the risk of heart disease goes down by half. I don't know, we'll completely go back to normal, but certainly damage that's done to the blood vessels will heal itself with quitting. And so it's just very important to not start smoking. And if you're smoking, try to cut back, and then quitting would be the best. Also,
pardon the interruption, Dr. Stubner. Can you share the slides again, please?
Oh, sorry.
Thank you very much.
Let's see. Okay. And then, are we good again?
Yes, thank you.
Yeah.
Okay. So, well, you heard what I was saying about smoking, but another interesting to think about, when we started instituting community smoking bans, 20 years ago, we saw a decrease in the heart attacks in non-smokers. And so that was, I remember being taught in medical school that secondhand smoking, we didn't think was a problem. And that's clearly not the case. So that, I think that's a consideration. If you're smoking, there's children in the house, there's certainly risks that come with that. But even, adults, friends, relatives, and so forth, there are certainly issues with secondhand smoke that not being healthy as well. So, we've had a lot of success in decreasing smoking in the US. Vaping is probably not healthy either. In some ways, maybe worse. We don't quite have as much data, so I don't want to kind of overextend or make too many comments, but the data that we do have doesn't look like it's good either. And I just think of that concept of breathing in clean air as much as possible as being a good thing. So cholesterol is a fat-like substance in the body, and we get it from two ways. We can take it in, so eggs, shellfish, things like that have actual cholesterol, but most of our cholesterol we make. So all of the cells in our body make cholesterol, the liver and every other cell, because we need some cholesterol for our cell membranes. We need it for hormones, things like that. However, most of us have too much circulating cholesterol in our circulation, and we think that's largely due to our intake of saturated animal fat, which then causes us to produce too much cholesterol in our body and in our liver. In foods, cholesterol tends to be in animal sources, but again, we think most of the concern is the saturated animal fats and the level of intake. So when there's a sort of the whole sort of metabolism of cholesterol is fairly complicated, but in a general sense, there are some good cholesterol lipoproteins called HDL, and that's high, it's a good thing. And then when the bad cholesterol, LDL, is high, that's bad. So we want the LDL to generally be very low, and we want the HDL to be high. So generally on a cholesterol panel, you'll get your total cholesterol. They'll measure the triglycerides, and then they'll measure the HDL. The LDL may in fact be calculated off those other levels, or it can be directly measured. So as a general rule, we want a low total cholesterol, high HDL, low LDL. The triglycerides aren't as directly associated with heart disease, but also those are beneficial when they're lower. Sometimes when those are elevated, it can be a marker of insulin resistance or metabolic syndrome or even diabetes. So the few more comments about cholesterol and atherosclerosis. This is an editorial from Dr. Roberts. He's actually at Baylor Scott White up at the Baylor University Medical Center in Dallas. He's been the editor for many years of a heart journal, and he's asking a question in this editorial. Is that, do we have multiple cardiac risk factors, or they're just one? And is that one risk factor just atherosclerosis or high cholesterol? And what he points out in this first comment is that atherosclerosis is easily produced in an animal model, in a non-human herbivore, say like a rabbit or a monkey. All you have to do is give an herbivore a high cholesterol, high fat diet, and they will get atherosclerosis. And he points out they don't get them some, they get it 100% of the time, they get atherosclerosis. Now, if you were to take a carnivore, say like a dog or a wolf or something, they do not get atherosclerosis easily unless you create other conditions, because they are physiologically designed for that type of diet. He also goes out to point out that if you look at our physiology, we have a lot more in common with an herbivore than a carnivore. We have color vision to see, fruits and vegetables. Our teeth are more like an herbivore. We have a long intestinal tract. It takes more time to digest. Shorter digestive tract, how we cool, how we drink fluids. Some internet's maybe get unstable again. How we have to get vitamin C from our diet, as opposed to carnivores make it. So all of these things sort of make us think, yeah, we probably need to be eating more of our vegetables. So he says if we could decrease our meat or flesh intake to 5 to 7 meals per week, our health would improve. Then also goes on to say that there's a lot of health conditions that are uncommon in parts of the world where they don't eat a lot of meat. So anything from high blood pressure, as I mentioned earlier, diabetes, some of the conditions, some of the cancers like colon cancer, things like macular degeneration, we see less commonly in places where they don't eat as much animal meat. So, it's tough for me to hear growing up in Central Texas as well, but, over time I've been trying to, I don't know that I think there's still room to eat animal protein and meat health in a healthy way, but trying to eat more vegetables and stuff as the basis of your carbohydrates, I think is the goal. Blood sugar, also important. And so when talking about blood sugar, that's glucose, so your serum glucose, and then also how your body responds to glucose, which is your insulin levels. And so basically the way I think about it, if you're eating a lot of refined, sugars, refined carbohydrates, so, obviously anything with sugar in it, candy, sweets, chocolate, stuff like that, or refined carbohydrates. So white bread, white flour, white rices, that sort of thing. So like a pancake would be a good example. It's white flour with syrup. Those kind of things are going to cause an immediate spike in your blood sugar. You're going to get, it's easy for your body to break it down and get it into your system. So your blood sugar is going to go up. and then your body's going to have to produce a lot of insulin to help process that sugar. And then what happens if you've all had pancakes and didn't have anything else, your blood sugar is going to crash. You're going to get that kind of jittery, uncomfortable feeling, almost a clammy feeling, just because your blood sugar is now low. And so that kind of that up and down pattern over time is not a healthy way to eat and can lead to insulin resistance. And as opposed to, let's say you go back to the example of carrots. Some carrots are carbohydrate as well, like a pancake, but it's a carbohydrate that's loaded with dietary fiber. And so your body's going to have to deal with all that fiber to get the carbohydrate. So instead of getting a spike in your blood sugar, you're going to get more of a slow, sustained blood sugar that's not going to be quite as high, and you're not going to get those swings in your blood pressure and then the swings in your insulin. So, so knowing, how you eat and how it affects your blood sugar. Also knowing that exercise helps you burn muscle glycogen, which is essentially the storage form of glucose, and then maintaining a healthy weight also can help minimize insulin resistance. All of these things are important. Diabetes creates a lot of strain on your vascular system at a microvascular level in your nerves. And so trying to prevent that is very important. And if you do develop diabetes, controlling the blood sugars is very important as well. We used to think if you get diabetes within 10 years, we could expect all of the complications of diabetes. We now know if it's well controlled and well monitored, that does not occur. So it's very important if you do get it to try to manage your blood sugars as best you can. So this Life Simple 7 that I've been talking about, if you kind of look at it in summary, there's sort of poor, intermediate, and ideal sort of goals. The ideal would be for smoking to never have smoked or quit more than a year ago, have a healthy BMI of 25 or less, the physical activities I mentioned of 150 minutes of moderate a week or 75 vigorous, a healthy diet pattern, total cholesterol below 200, blood pressure less than 120/80, and a fasting blood sugar of less than 100. It's simple, but simple is not always easy. It's that one study I cited from Sweden where they said if all 5 of those factors were present, there was an 80% reduction in heart attacks. The part I didn't mention is only 1% of people met all 5 of those criteria. So, some of this is not particularly dramatic or new, but it's still incredibly important, and it's still worth working at all these things just to do the best you can. And I think these are principles that have been known for a long time. And this editorial that I cited here, the author says, Hippocrates said years ago, if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to health. And I think these principles of the American Heart Association do a good job of highlighting that. I'm going to go ahead and I'll keep moving. I'm going to shift topics a little bit to some of the more things you may have seen in the news or some of the current ways in addition to this foundational stuff. But I just in closing, I don't think it's ever a bad idea to kind of revisit these foundational principles that are demonstrated in this Life Simple 7. So when a doctor is looking at all of these things, well, what do they do with the information? So if we know your age and your gender, if you smoked or not, cholesterol, blood pressure, how does that sort of determine what do we do with that information? Well, there's these things called risk assessment calculators. The traditional one that's been around for a long time is called the Framingham score. And what they've done is look at large studies of large populations and looked at these risk factors and try to determine what are people's risks of heart disease on the presence or absence of the risk factors. A primary risk factor is just getting older, and so that's a fact. That's an input in all of these calculators. But when we plug in all that information, what these tend to give us is what is the risk of an individual patient's risk of heart disease within the next 10 years. Now, we still care about lifetime risk, but in terms of actionable information, that's what we have data for. And what it tries to do is personalize the decision-making on how aggressive do we need to be with blood pressure, how low do we need to get the cholesterol, what other testing might we need to do based on someone's risk. So if you have a low 10-year risk, we still want you to eat healthy, we still want you to exercise, but maybe we can hold off on starting a cholesterol medication, for example. If your 10-year risk is high, we have studies that show, well, maybe we need to be more aggressive with certain treatments, such say as lowering the blood pressure, for example, or lowering the cholesterol. So these are probably the three most commonly used. The Framingham, the middle one, is probably used more commonly for some of the studies, the ASCVD score. The Reynolds risk score was developed to sort of account for women. As you mentioned, many of these studies traditionally did not look at women, and so this was an attempt to add that. And then it also added something called HSCRP, which is an inflammatory marker, so looking at the role of inflammation. But none of them are perfect. All of them are reasonable, and they're a helpful starting point for your primary care physician or cardiologist to understand what your near-term risk is. And my only comment on that, I wish we could have a good estimation of lifetime risk, but we just don't have that data to work off of. So some relatively recent news, you may have seen this at the end of last year, some changes in the news in terms of should everyone be taking an aspirin. So this, I just pulled this the other day, but this came out back in October. It says most adults shouldn't take daily aspirin to prevent heart attack. This has actually been around in cardiology circles for a few years. But what this article was referring to was I don't know if the slide made it in. I think it's down here. Yeah, it's referring to this U.S. Preventative Services Task Force. And so they put out new guidelines in October. This is the committee that does things like make recommendations for when you should get colonoscopies or mammograms, things like that. And they had a change in their recommendations. And so basically, the idea is, is that aspirin, generally does provide some benefit to reduction in cardiovascular disease, but it comes at a cost. There's a potential harm in that it can potentially cause an ulcer or cause some sort of bleeding for some other reason. Well, that risk is not high, but in every decision we make, we want to sort of maximize the benefit and minimize the risk. And based on some more recent studies that came out in 2018, which I cited below, the ARRIVE, the ASCEND, and I believe the last one was the ASPIRE trial. It called into question the idea that if you're over 50, you should just be taking an aspirin. Basically, I think the ARRIVE study, if you were low to moderate risk of cardiovascular disease, you probably don't derive any significant benefit from the aspirin enough to justify the small risk that you get from it. However, though, if you're at higher risk, say you do have diabetes or you have a higher risk of CAD, of heart disease, you probably do still benefit from taking the aspirin. If you've never had heart disease and don't have any signs of it and you're older, likewise, there's probably not a benefit in starting an aspirin or taking an aspirin. So it's a decision that sort of gets into knowing what your individual risk is and a conversation with your doctor about it. But when we first started bringing this up a few years ago, people were very resistant to the idea that you shouldn't take an aspirin, or you should or shouldn't. But with the new news out there, it really just boils down to you as an individual and your individual risk. But I just mentioned it because if you're in a doctor's office and they say, oh, you don't need to take an aspirin anymore, this is where that information is coming from. It's trying to balance the risk versus the benefit. Going back up a little bit, came out more recently, this idea. So probably going back 20, 30 years, there's been this idea that mild to moderate alcohol consumption is good for your heart. Like if you don't drink, you need to start drinking because there may be some benefits to having 1 or 2 servings of alcohol per day, just to be clear. And there were some early studies that indicate that if you do have no more than, say, 2 servings a day, that may be beneficial. Now, there's been some pullback recently based on some more recent studies the last few years. I think there's still some question as to how harmful it is, but to say that it's good for your heart, I think is questionable. And some of the studies are saying, well, there's no safe amount of alcohol for the heart. The other thing is, if you look at alcohol consumption in general, when use goes up, there's more sort of incidents with accidents and so forth. And the other thing is there's effects outside of the heart that may have an indirect impact. Some people tend to not sleep as well, even though it's a sedative. You don't get as restorative sleep. Some people's blood pressure is affected by it. Some people get heart rhythm issues with even small amounts of alcohol. So I think that you're going to start seeing a pullback in this year and the next few years as to this idea that alcohol is sort of good for your heart, and that some of the more recent studies indicate that's not the case. And that idea probably would have been disputed by sort of other specialists, the oncology community, for example, and maybe the GI community, that there's sort of a safe amount or that it's good for you in some kind of way. So anyway, that's some newer information. I think we'll see more, more in this area of research here in the next few years. And this is I think, citing a study from the Lancet a few years back that just said even one drink a day increases the risk. So they won't really call it an average person. There's some advanced cholesterol tests available. There's a whole host of them. There's something called lipoprotein little a, apolipoprotein B. There's more advanced lipid or cholesterol analysis, looking at the size and the pattern of your LDL, meaning, so some idea if you have your bad cholesterol is called big and puffy, it may be less prone to causing cholesterol plaques as opposed to the small dense cholesterol. Also, some of these inflammatory markers I'd mentioned, high sensitivity CRP, SED rates. We know that inflammation creates risk for heart disease. So when do you want to get some of these tests are sort of still not quite ready for prime time because we don't always have treatments for things like high lipoprotein A, but when would you check these? If you have a family history of early heart disease, so if you have a primary relative like a sibling or brother or sister who had early heart disease, it may be worth getting a more advanced analysis. If you yourself have an early event and you don't have any of the traditional risk factors or minimal traditional risk factors, taking a closer look at them might be reasonable. Or if there's sort of a genetic disorder, something that maybe runs in your family, or you may be at genetic risk, maybe taking a closer look at these is reasonable. They're easily available. You can check these through a standard blood test through your doctor's office. Coronary artery calcium scans are also widely available. A variety of names, heart scans or Heart Saver, life scans, these sorts of things. The idea being you do a simple CAT scan of the chest. If you look at the picture on the left, you see the chest is sliced like a loaf of bread, so it's in cross section. The ideal look should be like the heart's in the center. You see like the bones are bright, but in the heart, there's no bright spots, just gray. We don't see any calcium. If you look at the picture on the left, in that circle, you can see bright spots that look like bone in the blood vessels. So that's coronary artery calcium. When we see calcium, we know the only thing that can cause that is atherosclerosis or cholesterol plaques. And so this is a useful screening test in middle age, at an age where ideally you'd still have no detectable plaque. And if you have more or high levels, we need to be more aggressive with prevention. There are similar tests. People have looked at carotid ultrasound to do the same thing. The idea is you're looking for evidence of early plaque, trying to prevent events. These are easily obtained. Fortunately, in the Central Texas area, the cost is usually pretty reasonable. Insurance, interestingly, doesn't cover these, but most places these days you get it for under $100 for cash pay. So I think it's a pretty reasonable test if you want to, in discussion with your doctor, if you're appropriate. Now, if you're under 40, unless there's a strong family history, this may not be a good test because even if you have plaque present, it tends to not be calcified. We can these days build on that further with what's something called a cardiac CT angiogram. This is a personal favorite of mine. This is for evaluation of symptoms. So if someone has chest pain, we can inject IV contrast, and it gives us these amazing pictures similar to what we would traditionally get by doing an invasive heart catheterization or an angiogram. And so the guidelines for the American Heart Association just changed at the end of last year, or I believe it was actually last month, saying this is now a class 1 recommendation for evaluation of chest pain syndromes. So essentially this similar to or take the place of a stress test. Instead of, we just look directly at the blood vessels and see, do we see any evidence of cholesterol plaque or not? And the advantage of this, when it's normal, it's the negative predictive value of this is over 99%. And we can even do, add to this, we can do called a flow analysis of the blood vessels. So you can do a specialized evaluation of the flow through all the blood vessels. And if any areas of the heart look like they aren't getting normal flow, then we have that precise information of flow assessment in addition to the anatomic assessment. So it's really allowing us with more precision to identify disease and then potentially determine if there's any need for, say, a stent or opening up of a blockage. That's all I've prepared. Probably enough anyway, but that gives us probably about 10 minutes or so if people have any questions or comments. Let's see if I can find the. I'll stop. Any comments or questions for anyone? I've got the chat up so you could type it in or do.
Thank you. I have a question. So how are, I guess, signs different, like a heart attack signs different for women than men, you know?
Yeah, so the traditional, I guess the textbook description of chest pain that represents the heart or angina pectoris would be a pressure, a tightness, a heaviness, or squeeze, the center or the left part of the heart brought on with activity, exertion, or stress, relieved with rest or a medication called nitroglycerin. So that's the classic description, and anything sort of similar but deviating from that is, kind of atypical. So the thought is women do seem to have atypical symptoms, meaning they may not always have that classic tightness. So, and I also find that's true in some older patients. And part of me wonders, is this just because women do tend to present 10 or 20 years later than men? And maybe that's that partly explains it. But yeah, we tend to say, well, you may not have those traditional chest tightness. So sometimes that means, well, maybe the symptoms don't occur with exertion or activity. Maybe it doesn't feel quite like a tightness. It's maybe just some achiness or an upset stomach type symptom. Maybe there's no chest discomfort at all. It's just a slight feeling of windedness or fatigue or shortness of breath that represents a change. And so anything along those lines, any kind of symptom from, the neck or upper arm down to the sort of the upper abdomen, we tend to listen to. And then another reason I really like it when people are active and walking is they notice changes like that. If they notice, I just don't have the same energy. I get winded, I get tired. That's what people tend to refer to for some of those atypical symptoms that can occur in women.
Thank you.
Mm-hmm. I see a question, how serious are heart murmurs? So a heart murmur essentially means that we're hearing blood flow through the heart. So if you think of blood as a liquid and you imagine water is a liquid, we hear water flowing. We don't really hear water flowing if it's coming out of a hose. We hear it when it hits the ground, or we hear if we turn the water up like on a fire hose, we hear it when it's going fast. And so if you go back to the heart, so when you would hear blood flowing through the heart would be if the blood's flowing quickly, or if maybe it's hitting something it's not supposed to. So what we usually worry about is does it represent a dysfunction in a heart valve, or does it represent some abnormal function in the heart where it's pumping or not doing what it's supposed to do? Sometimes a murmur doesn't mean anything. So if a child comes into the doctor's office, they have a fever, their body's fighting a fever, their heart's pumping hard, they can get a flow murmur. That can happen to adults too, but essentially means we hear blood flow and probably need to get an ultrasound to figure out what's going on. In terms of the second part, is there any dietary tips to add or avoid the condition? It sort of depends on what the condition is. If it's through something like high blood pressure, certainly that could create a murmur in certain circumstances, and low salt diet or healthier diet could help with that. If it's a valve issue, typically we haven't found any sort of dietary modification or intervention that would help with that. Any other questions or comments, or in the chat or on the microphone? for any hands up. I don't see any. Oh yeah, there's a question. How beneficial is fish oil omega-3s? So that omega-3s are a healthy unsaturated fat, and so they are beneficial to have in our diet. And so you can get them through fish oil, other sources, I think flaxseed, and there's some other sources as well. And so we do need omega-3s in our diet, and most of us probably, if we're eating the traditional American diet, get too much. We need a healthy balance of omega-3 to omega-6, and we probably get too much omega-6 and not enough omega-3. So you need to take a fish oil supplement, is a question we get. If you like seafood and you eat fish that's high in omega-3s, there's probably not that much additive benefit in taking a fish oil supplement. If you don't like fish and don't eat it, there may be a role for it. The caution with this, you have to pay attention to the fish that you're eating or the fish oil, that supplement that you're taking, because then we have to worry about mercury content. So certain fish like tuna can be high in mercury. And so you also have to, there's kind of a caution about not eating too much tuna, no more than once a week or so. But then salmon, as I believe is also a good fish for omega-3. And so certainly we think there's a role for fish or fish oil and omega-3s in your diet. So that's definitely good to have that. See a question on heart palpitations. Heart palpitations we refer to as a symptom of awareness of a heartbeat, a skip beat. They're very common. I feel like especially during the pandemic, they've been more common. The way I describe them, if you ever had an eyelid twitch or a muscle twitch, it's like the same thing happening in your heart, and so it generates an awareness of your heartbeats, which is pretty uncomfortable. I've had them too, and even though they're usually not dangerous. So things like fatigue, stress, dehydration, maybe too much caffeine, just being, on the go, stress kind of stuff tends to trigger them, and they seem to be more noticeable when you're trying to sort of relax, sit down, things like that. They can sometimes, if they have other symptoms or have a lot of them, maybe they're actually a sign of an abnormal heart rhythm. But I'd say the most common thing is they just represent sort of skipped beats. So iron supplements, are iron supplements safe to increase iron along with diet? It sort of depends. You can definitely overdo it with iron. So it sort of depends on what your levels are. So if you are anemic, we certainly need iron to help maintain and produce red blood cells. Men probably need to not take too much extra iron in, and anyone potentially can overdo it with iron, but it kind of depends on your individual blood counts and if you need iron or not. Women of reproductive age probably may need it depending on blood counts. That'd be a question to discuss with the doctor. After that, it just kind of gets, some people that don't eat a lot of animal protein, they may need iron supplements if they tend to run low blood counts, but it sort of depends. In general, men don't need iron supplements. I do have a few patients that don't really eat any red meat, and they do sometimes take some iron to help boost their blood counts. The supplement question, red yeast rice was recommended. So red yeast rice can help lower cholesterol. The reason that it's helpful actually is it actually has a natural statin type. Well, the ones that are helpful, it has a natural statin type drug in it called Mevacor. And so that can certainly help lower cholesterol, and it's essentially a way to take a statin drug at a mild dose. I'm not opposed to red yeast rice. Now, some versions don't have the actual effective component in them, and it's hard to know with supplements what you're getting sometimes. And then the other issue is the cost. That if it's an effective supplement, I tend to notice that the price tends to be expensive, and it's often more expensive than the prescription version. So you could take a generic version of atorvastatin or simvastatin and probably get a more effective cholesterol reduction at taking one pill a day versus the red yeast rice usually wants you taking 2 pills twice a day. But it's there's not a harm in taking red yeast rice. But in terms of can I recommend it, it gets harder to, because it kind of gets determined which supplement company is making it and how reliable is it. If it's a reliable store, they probably buy from reliable companies that test the products. And so, but But that's where the benefit comes in, is in lowering the bad cholesterol. Another question, are sleep disturbances hard on the heart? Question is, yes, they are and can be. It's incredible. Like I recall in med school, we didn't quite know why people needed to sleep at night. But I mean, in the last few years, we know it's incredibly important to get restorative sleep. So if you have, conditions, say like sleep apnea, where you don't get restive or restorative sleep each night, it tends to lead to high blood pressure. And if it's really severe, it can even trigger abnormal heart rhythms. And so it's potentially dangerous to have untreated sleep apnea, depending on the severity. But generally, if you get poor sleep, it does affect your blood pressure. It causes things like heart palpitations and just your general, feeling well rested and ability to exercise. So yeah, it's very important to get a good night's sleep. I think the days of this, it's idea that, yeah, I remember it's these people that could get by on 2 hours of sleep, and we should all be in envy of them. I think there's still that people that don't need much sleep, but most of us need to get a lot more sleep than we do. Any other questions? Well, I think we're coming up on the, okay, yeah, I think we're coming up on the end of the hour. So if anyone has any particular questions, we're up in the Arbuda location, and then we have a primary care office in San Marcos. And then we're always available if you need us, but appreciate the time today. Always enjoyed. We always want to keep people healthy, and then maybe eventually I can go find something else to do.
Well, thank you so much. We'll be sending out a course evaluation. So if y'all could please take a few minutes to share your feedback, we'd really appreciate it.
Perfect. And thank you so much, Dr. Stobner, and then everyone at Texas State for having us.
Thank you. Take care. Have a good day.